happy?
Yep. So shall I start?
Yep.
Brilliant. So I think I know most of you, but for those of you that don't know me, my name's Nosheen and I'm a ST4 Diabetes and Endocrine Reg at the Northern. So today's teaching is about DKA and HHS. So we're going to go through both conditions, define what they are, describe a little bit about the pathophysiology. Just from my point of view, I think it's easier to remember what we do if we understand why it is that we're doing it. Look at the risks of the conditions and the treatment, how we treat the conditions, common pitfalls that arise, things that I'm asked quite frequently, and importantly, when to escalate to either a reg or to level 2 care. Quickly go through the differences between the two conditions and then go through managing a simple raised blood glucose out of hours, which is something that we obviously have every single night. And I think everyone sort of struggles with because there's so many options of different treatments. So I'll try and simplify that for you guys. And then we've got a few cases at the end. I've been asked to make the session interactive, so there will be some questions. So when I ask questions, if you could just, put your hand up sort of remotely. And I think Helen will sort of call on you guys to answer the questions if you volunteer. So just references that I've used, the ABCD guidelines, if you just Google them, the HHS guidelines were written by Dr. Scott, actually, they're the national guidelines, and then there's DKA guidelines as well as other things. And then I've used the Oxford Handbook of Endocrinology and Diabetes, and I've used sick day rules as per Daphne. So that's a national course that we send our type 1s on to learn to manage their own diabetes, but it's quite useful, just general principles. So I've quickly gone over that at the end as well. So we'll start with DKA. So first bit of the interactive session. Can anyone define what is DKA?
A high blood sugar level that alters your physiology.
Yep. Anything more to it than just high blood sugar? So I will break it down. So DKA, so diabetic is the D. So blood glucose greater than 11 or known diabetes. So confusingly, you can get something called euglycemic DKA, which is where you have DKA but with a normal blood glucose. It's not as common, but you just need to be aware that condition does exist. So you can have DKA with a normal blood glucose. If it's going to happen, it's usually pregnant women or people taking the medications that end in gliflozin. So you may have come across canagliflozin, empagliflozin. They're known as SGLT2 inhibitors, and euglycemic DKA is associated with them. So the first thing is diabetic. Second is ketones. So if we're looking at blood ketones, it's greater than 3, and urine ketones, it's 2+. Urine ketones, fine in the initial diagnosing process of diagnosing the DKA, but we do need blood ketone monitoring thereafter. So I know there are some wards that don't have blood ketone monitors. If someone's going into DKA or has DKA, then we need to essentially get a ketone monitor from another ward. And then acidosis. So pH less than 7.3 or bicarb of less than 15. So by those criteria, you'd think that the diagnosis for resolution would just be, the opposite of that, but it's not quite. Does anyone know how we diagnose resolution of DKA? So when can we be happy that we can stop the treatment and that they're out of DKA? Any volunteers? So essentially, so we want them to no longer be acidotic, so pH of greater than 7.3 or bicarb of greater than 18. So just notice that the bicarb has to be just that bit higher again. And then the ketones need to be fully resolved, so less than 0.6, so basically completely cleared. So if the ketones are still, 1 point or 2 point something, then we need to carry on. Importantly, again, it doesn't matter what the blood glucose is at this point, because as I said, you could have DKA with a normal blood glucose. So we're not too fussed what the blood glucose is in order to diagnose resolution of DKA. So the aims of treatment are to reduce the blood ketones by 0.5 millimoles per litre per hour. We also monitor the bicarb or pH, but that's usually as a substitute when blood ketone monitoring isn't available, but we'd rather have the ketones. We want to maintain the potassium within the normal range, avoid hypos, and avoid complications of DKA or of the treatment itself. So I'm just going to quickly go over the physiology. I'm not going to go into too much detail, but as I say, I do think it's important to understand why things happen, just because then it's easier for me anyway to remember what we do. So from sort of biology, you know, glucose plus oxygen is CO2, H2O, and energy. So the important thing about this is the glucose needs to be in the cells in order for us to use the glucose. So when we've got hyperglycemia, that's a lot of glucose knocking around, but it's in the blood, it's not in the cells. So if it's just knocking around in the blood, it's not actually very much use to us. We want it to be pushed into the cells. An alternative form of getting energy for our body to respire and our cells to respire is, instead of using glucose, is to break down fats. That's a less efficient source and results in fatty acids and ketone bodies, so ketones. So if we've not got the glucose within the cells, we start breaking down fats. A bit of a busy slide now, but essentially the important bits are when our blood glucose goes up, i.e. glucose within the blood, we get insulin released from the pancreas, and the important bit is the sort of central bit here. The insulin pushes the glucose into the cells, so it stops the blood glucose from going up, you know, it stops that number from rising, and it puts it into the cells where we can actually use it. You're not having insulin released from your pancreas, i.e. type 1 diabetes, or you've had a pancreatectomy, something like that, then all these other bits don't happen. So the glucose will not be pushed into the cells, and basically it will just keep going up and up. In response to that, we aren't able to break down glucose, so we start breaking down fats. And that's how we get ketones from. So this is a bit of a summary of all that more busy slide. So we don't have enough insulin on board for whatever reason. So the glucose goes up in the blood and it's not in the cells where we can use it. Therefore, we start breaking down fats, and that forms ketones. So it's more recognised in type 1, because with type 1 you aren't producing insulin yourself, but it can occur in type 2 less frequently. And when you've got hyperglycemia, i.e. too much glucose within the blood, it causes an osmotic diuresis, which is basically your body is trying to pee out the excess glucose. And in doing so, as well as peeing out the glucose, it drags a load of water with it, and you end up dehydrated. So important to know, typical fluid losses are around 100 mils per kilo. So in an 80 kilogram person, you'll be in an 8 litre deficit. And of course, when you're losing all the water, you're also losing all your electrolytes as well, which comes with especially the potassium, comes with, you know, the risks of hypokalemia. So the risks are associated with the movement of fluid. So you've got risks of cerebral and pulmonary edema. Of course, we're then going to treat them with fluid. So you've got the risks of becoming very dry, and then the risks associated with giving them a lot of fluid. And, you know, we need to be aware pulmonary edema is something that we think about a lot, but we may not think of cerebral edema when we're giving people a lot of fluid, and that, you know, people that are dropping the GCS, we need to be aware of that. There's a risk of acute respiratory distress, increased risk of clot because they're very dry, hypovolemic shock, and electrolyte derangements. And the ones that we most worry about are hyper and especially hypokalemia. So if people are very dry, they might get an AKI, which may be associated with hyperkalemia. That should resolve with us treating the fluid losses. The ones that we're more worried about are the ones that are hypokalemic to begin with. So if they are, you know, if they've got low potassium and we then start insulin treatment, that may push the potassium even lower still. So they're the ones that we need to worry about. So DKA treatment. So we'll start off first with who do we need to escalate early. So anyone that we would possibly struggle managing the fluid balance. So that's just the same as in any scenario. So very elderly, they're frail, they're skinny. You know, we worry about pushing these people into pulmonary edema, cerebral edema. Quite young, pregnant people, obviously these people we just need to be really careful with. And those with serious comorbidities, so cardiac and renal failure, they're just at increased risk of going into fluid overload. Unable to gain access and difficult blood taking. So, I mean, we've all had, I mean, it does seem to be the way that all of the DKAs are difficult to get access in. And it's something that I think we don't take seriously enough. So we need to have proper access. So if we're unable to get access, or we're getting to the stage where we're not able to bleed them anymore, that does need escalating, and that may well in itself be an indication to go to HDU. So if they're needing a central line essentially, it needs to be escalated early so that can be facilitated. And then what we class as severe DKA, which I'm coming to now. So severe DKA, these patients should be on HDU, and these are the patients that they may need arterial lines or central lines, because we need to be monitoring them closely, and we need to be keeping an eye on their electrolytes and fluid status. So very high ketones, greater than 6, very acidotic, so bicarb less than 5 or pH less than 7. Those with hypokalemia, so as I say, especially at the beginning of treatment, if they've already got a low potassium and we're going to be giving them a lot of fluid, which will dilute them, and insulin, which will also worsen hypokalemia, they may need to go to HDU for neat IV potassium treatment. Anyone who's dropping the GCS, there's a risk of cerebral edema. Anyone who's hypoxic or becoming hypoxic, so there's a risk there of pulmonary edema. And anyone who's shocked. So the treatment, we tend to separate into the first hour, and then up to 6 hours, and then 6 hours thereafter. So I'll separate it that way now. So up to 60 minutes, and this is probably too much to do in 60 minutes, but this is what the guidelines say. So can anyone tell me what is the treatment out of all these options? What is the treatment for DKA? Anyone?
Is it the fixed rate IV insulin?
Correct. Fixed rate insulin. And anything else?
IV fluids?
Correct. Is there anything on here that is definitely not the treatment for DKA?
Antibiotics.
Dextrose.
Anything else?
Oh, yeah. It says variable fixed rate. Is it? No.
So IV fluids and fixed rate is the treatment for DKA.
Yeah, it's the other one.
And the variable rate is not a treatment for DKA. The other thing that isn't a treatment for DKA is bicarb. So that's something that we get asked about quite commonly, because people, well, understandably, see a pH of 6.9 and a bicarb of 4 and want to do something about that. But giving IV bicarb isn't actually going to help. The reason that they're so acidotic is because the ketones are so high. So what we need to do is treat the ketones. And if we give them IV bicarbonate, it can actually worsen the shifts in fluid that can precipitate cerebral edema. So everyone wants to give bicarb, but it doesn't help the patient. It just feels inherently like something that we should do for someone with a bicarb of 4, but we shouldn't in these cases. Everything else on here does come into the treatment somewhere. So at some point we may start dextrose. For some patients, they may need antibiotics, depending on why they've gone into DKA. They may need IV potassium, and they will need low molecular weight heparin. So our aims in the first hour are to thoroughly assess the patient, essentially. So identify those who are unwell and escalate early. Start restoring their circulating volume, commenced fixed rate IV insulin. And then we're thinking about what are the precipitating factors. So why has this patient gone into DKA? And start the treatment for that. So some of the patients, it's quite simple. It's they didn't know they had type 1 diabetes and this is the first presentation, in which case the treatment is treating the type 1 and treating their DKA. Some of them, they know they have type 1 diabetes and just don't take their insulin. That's a factor as well. But it may be something else. So things like sepsis, do they have a horrible gangrenous foot that they've not told you about? Are they pregnant? Are they having an MI? Especially people with diabetes may have silent MI, so it may not be obvious. So we need to just consider all these things and initiate investigation and treatment as appropriate. So those investigations, we can do point of care testing with capillary glucose, blood ketones, and VBG. VBG is useful for many things, but we can obviously monitor the glucose. So the capillary blood glucose monitors only go up to 28.7, I think. So anything higher than that, and we do need a VBG. Also gives us a quick turnaround for the potassium instead of waiting for UNEs, and lactate, as well as looking at the acidosis. Lab bloods can be sent off. Septic screen as indicated. ECG, pregnancy test. Pregnancy test is the one that always gets forgotten. So, more important, they should be doing that in A&E, but by the time they come to AMU, if it's not done in a woman of childbearing age, then we need to do that as well. So we start off by fluid resuscitating. Now, I'm not going to go into this in detail because it's on all of the guidelines in every hospital, but essentially we give them a lot of fluid. The first litre we give over an hour, and then thereafter it's 2 hours, and we give it with potassium. Some places may worry that we're giving the potassium quite quickly. That is the guideline. If they're concerned, what we can do, what I've done before, is instead of putting up 1,000 mils in one arm, you can put like 2 500 ml bags up and run them simultaneously into different cannulas. Sometimes that just makes people feel a little bit better about giving the potassium so quickly. So if they're hypotensive, we just fluid resuscitate, as we all know how to do. So, give them a fluid bolus, reassess, give them a fluid bolus, reassess. If they're not improving after a litre, if they're still hypotensive, then that needs escalating quite quickly. And once they have improved, once the blood pressure has improved, we go back to this previous slide and we just follow on from there. And the IV insulin, again, this will all be on the guidelines, but so it's fixed rate and it's based on their weight, and we round up to the nearest 10. So someone who weighs 80 kilos, it's 0.1 unit per kilogram per hour. So you just divide by 10. So if they're 80 kilos, 8 units per hour. And we prescribe 50 units of Actrapid in 50 mils of normal saline. And the other important thing to do is if they are already on a long-acting insulin, and I will come to the different types of insulin later, we must make sure that that's continued. So if they have been taking their normal insulin at the usual time, just continue it at the usual time. If they have been omitting their insulin, and that's the reason they've gone into DKA, just give it now. So Levemir, whatever it is, Toujeo, just give it. Make sure they've got some insulin on board. And then we replace the potassium. So if they're hyperkalemic, obviously we don't add any potassium into the fluids, but we will monitor that and it will start to drop with the IV insulin in the fluid. So we keep an eye on that. And then once it comes into normal range, it's 40 millimoles per litre of normal saline. If they are hypokalemic, as I've already mentioned, we'll be escalating them because they may need to go to HDU. So in summary, for the first hour, we just need to do an A to E assessment, get them started on the IV insulin and fluids, and escalate those that need escalating early, and start trying to think about why have they gone into DKA and start treatment if we can. It's a lot to do in an hour, I know, especially for those that you can't get a cannula into. So the next up to 6 hours. So at this point, this is where we get into the monitoring stage. So we hope the aim is, as I mentioned earlier, is to clear the ketones basically. So clearing them by 0.5 per hour. Keep the potassium in normal range with monitoring, avoiding hypos, identifying and treating precipitating factors, and continuing long-acting insulin. Give the dolteparin. So if someone comes in at 9 o'clock at night, they will be dry, really dry, and we don't really want them waiting until 6 o'clock the next evening for their dolteparin. So if they come in and we're seeing them on AMU in the middle of the night, we should just do a stat dose. It's something that isn't done that commonly really. So we'll be monitoring them hourly with use charting. We should be doing a urine output. Now, a common issue here is that a lot of the people that come in DK are young adults who do not want a catheter. So what I would say here is if they are awake, able to either use a bottle or a commode, and you think they are trustworthy at doing so, and they tell you that they have been peeing, then you say that is fine if they're really against a catheter, but I say if you have not peed within the next 2 to 4 hours, you are getting a catheter, and that often brings people around. So they say, yeah, that's fine. They understand why it's needed. And if they keep, oh, I forgot to use the bottle kind of thing, they're going to end up needing a catheter, because we need to know that, they're not going into renal failure. We need to be doing the capillary glucose and blood ketones every hour at first, and keeping on reviewing the fluid status because we're giving them a lot of fluid. VBG is for their potassium, and it may need doing more frequently if the capillary glucose is too high for the meter. So we're keeping an eye on these people very closely. So we aim to for the ketones to fall by 0.5 every hour. So that's quite self-explanatory. We're also monitoring the bicarb pH and the blood glucose, but the ketones are the key here. That's the most important thing. So what if they aren't improving? So what if the ketones just aren't shifting? So what we need to do is, before we start increasing the insulin, we need to make sure that everything's actually plugged in properly. And it seems really obvious, but this does happen. So I've had it where, I've said, are we sure that everything's working? Are we absolutely sure? Yeah, everything's plugged in, everything's definitely turned on, the cannula's in, and then you go to the patient and the cannula's fallen out. But if the insulin is only going at maybe 6 mils per hour, it's not like when you've got a litre bag of saline dripping onto the floor. You'd notice that, but you wouldn't notice 6 mils in an hour dripping into your bed necessarily. So what you need to do is check everything's turned on, check everything's set up correctly, check that it's actually, nothing's blocked off, run out of batteries, anything like that. If all that is correct, what you want to do is ideally put a new cannula in, get a new pump and a new insulin syringe, and just start from scratch. If they're really hard to cannulate and you can't get another cannula in, the other important thing is if you've got 2 things going through the same cannula, so you may have, a bag of normal saline and, sorry, that's my cat. If you have a bag of normal saline and some IV insulin, then essentially make sure that the normal saline isn't just free flowing. You want it through a pump so that you're 100% sure that it's all going forward in a straight line and that it's not, tissued, and actually the insulin's just going up into the bag of saline. So once you've done all of that, made sure everything's definitely plugged in and that you're definitely happy with everything, then you can start increasing the rate of insulin by 1 unit per hour until the ketones start falling. So once the patient does improve, and they will eventually, sometimes the first hour or 2 things are a bit static and everyone panics, but they will. Once the blood glucose is less than 14, you start dextrose, and you continue until DKA is resolved as per the definition that I mentioned earlier. So does anyone know why do we start dextrose, and why don't we just decrease the insulin when the blood glucose starts to fall? Anyone?
Is it something to do with potassium?
Not quite. So just for a bit of a clue, so basically, I guess the other question would be, if we start the dextrose and the blood glucose then starts going up, would we stop the dextrose? What would we do in that scenario? So essentially, when we've got the IV insulin going through, we'll be pushing the blood glucose down and it will go into the cells and it will start to be used up. If we then obviously start the dextrose because we don't want the blood glucose, we don't want them going hypo. It's the insulin that will be clearing the ketones. So we cannot start decreasing the insulin until the ketones have cleared and they are out of DKA. So if we start putting dextrose up and the blood glucose starts going up, what we do is we just increase the insulin. And the reason for that is that we need the dextrose, because once we've been pushing all this blood glucose into the cells, it will get used up and then they'll just run out. So what's in their cells, they'll start running out of, and essentially they'll just go back to breaking down fats. So the reason that we're starting dextrose is to give them something, basically give the cells something else to eat, so that they don't then just go back into breaking down your fats and essentially go back into DKA. So with a sliding scale, it's a bit different. With the variable rate, that's a different scenario. But when you're on DKA protocol, fixed rate, when you start the dextrose, you don't stop it. If you need to, you increase the insulin. And that's what you do. So you just don't stop it. I can come back to that at the end. I don't know if I've explained that well, but if you've got any questions at the end, then I can go back over these bits. And then after the 6 hours, thereafter, it's basically everything should have improved. If it's not, then we need to be getting help. Continue IV fluid as needed. So essentially, hopefully at this point, they're out of DKA. But if they're not, we just continue. At this point, if after 6 hours, if you've been using the bicarb instead of blood ketones, so if you're somewhere that you only have urine ketones, and therefore we're using the bicarb, by this point you'll have given them so much normal saline that they will start becoming acidotic. So just to be aware, the options are either see if they still need fluids. If they do still need fluids, we can change over to Hartmann's if needed. But, you know, at this point, they may well not need any additional normal saline. They may be feeling better, stopped vomiting, able to eat and drink. And obviously, everyone that comes in DKA, or especially goes into DKA in hospital, needs to be referred to the diabetes team. So when the DKA has resolved, we want to be basically getting them back onto subcut insulin. If it's the middle of the night and they're asleep, they're not eating and drinking, you know, then we'll probably put them onto a variable rate. We want to switch them over at a meal when they're able to eat and drink. So if they're still vomiting or they're drowsy or anything like that, then we'll leave them on a VRI. But otherwise, when it comes to, it's usually breakfast, isn't it? Because these things always happen at night. Then we can give them the normal quick-acting insulin, and their long-acting should have been continued or restarted, and then we can switch them over. At this point, obviously, we will refer them to the diabetes team who can advise about all of that bit. So, common pitfalls. Don't stop the dextrose. So that's what I was just harping on about. So once the dextrose has started, we don't stop it. You know, even if I've not explained it very well, just remember that. Don't stop it once we've started it. If the blood glucose starts going up, if we need more insulin, we just increase the insulin. We don't start stopping the dextrose. Euglycemic DKA, be aware that it exists. Other causes of ketosis. So diabetes isn't the only cause of ketosis. It can be alcoholic ketosis, starvation ketosis. So if you see someone that doesn't look particularly unwell and you're not quite sure what's going on, you can just have these things in the back of your mind. Remember to try and figure out why they've gone into DKA. So, as I say, in some people it's really obvious they've just not been taking their insulin, but in other patients, especially those in hospital who shouldn't have been emitting their insulin, we just need to look if there's something underlying this that we need to look into. We don't need to keep stabbing them. VBG is absolutely fine for this purpose. They only need an arterial blood gas if they become hypoxic, and we're monitoring them for that reason. Always remember to continue the long-acting insulin. Poor IV axis. Can we use one cannula for everything? Well, not if they're on about 3 things, but if they're at the beginning, if they're only on normal saline and IV insulin, that is acceptable as long as they've both got pumps and we're happy it's a good cannula. Urine ketones is fine for diagnosing. We can't monitor with urine ketones. And low phosphate. So this is something I only found out about last year. People with DKA get low phosphate. It doesn't need treating. So a lot of these patients, you know, they've already got so many IV drugs going through, and they end up on a polyfuser as well. It's another thing to monitor. They don't need it. When the DKA resolves, the hypophosphatemia will resolve. So as long as they're not symptomatic from it and they don't have something else going on like refeeding syndrome that we actually need to really worry about, you can kind of ignore the low phosphate. Don't be tempted to start giving them IV bicarb. So on your left, you've got the ones that you continue while they're on an IV insulin infusion. On the middle and right, you've got your mixers and your short acting. You don't continue those. Human IV, I've just put a star next to it because it's technically not long acting, it's intermediate acting, but you know, it counts as long acting. So anyone that's on Levemir, Lantus, Tresiba, Toujeo and Humulin I, continue those ideally at their normal time, but if they've been missing it, just give them some. Don't give them that, and do give them that. Okay, before I move on to HHS, does anyone want to ask me some questions about DKA?
Can I ask something regarding the dextrose?
Yep.
So when you're monitoring it on there, and if it says if your BM is less than 12, do we start the dextrose and continue the dextrose despite the BM going high? I'm a bit
Yes.
confused. Yeah.
Yeah. So
So
I
if
think
it
it's 14 in a fixed rate for DKA. It's 12 on the sliding scale.
Right.
I think that's right. But obviously, if it's something different on local guidelines, then follow the local guidelines. But so when the blood glucose comes down to less than 14, you start the 10% dextrose, and you continue it even if the blood glucose starts climbing again. And if you need to, you can increase the IV insulin, but you don't stop the dextrose essentially.
Yeah. So if the BM is like 20, we still continue the dextrose. And
Yes. Yeah. Once you've started it.
once I've started, right? Okay. Fine.
Yeah.
Yeah.
So if it's say you when you diagnose them, they had a BM of 20, it comes down to 10. You've started the IV dextrose. It then goes back up. You don't stop the dextrose. You just increase the IV insulin.
Okay. Great. Thank you.
All right. And remember that actually, for them to have resolved DKA, it doesn't really matter what the BM is. So if they can still have a BM of 15, but as long as they're completely cleared their ketones and the acidosis is resolved, you'd still be able to stop the IV insulin.
Okay. Thank you.
All right. Anything else?
Can I just ask regarding the low molecular weight heparin? You said obviously initiate it straight away. I work in ED, so obviously we get quite a few patients through there. Would you initiate it in ED or wait till they get on the wards?
No, I'm happy for them to start it in ED. We do sometimes ask them to do that in resus.
Okay, fine, thank you.
It's just a prophylactic dose unless obviously indicated for a treatment dose.
Yeah.
It's just safer that they have it because they will be really dry.
Great, thank you.
All right.
Yep.
Anything else? Okay, so HHS. So everyone's seen DKA, but HHS is a little bit less much less common. So we'll go into that now. So does anyone want to tell me what the definition of HHS is?
I forgot the word now.
Yeah, hyper.
Is it osmolar?
Osmotic hyperglycemic state.
Correct.
Hyperglycemic.
Hypoglycemic. So with this one, the blood glucose is really high. So we're talking more than 30. Hyperosmolar, so serum osmolarity greater than 320. I think off the top of my head, the normal serum osmolarity is 275 to 285, something in those ranges. So it is significantly high. And then really importantly, this isn't in the title, but they are sick. They are really, really sick. So this is important, and it's a bit more difficult to quantify. But essentially, you can get people that are just walking around hyperglycemic and are technically hyperosmolar, because the serum osmolarity is actually the sodium times 2 plus urea plus glucose. So some people that have poorly treated diabetes, that just walk around, that don't take their insulin, type 2, that just wander around, they're always hyperglycemic. And they may have CKD, so they have a high urea, and depending on where their serum sodium is, they may technically fulfill this criteria. So they may be hyperglycemic and hyperosmolar, but they're well. So we get these patients in clinic that technically, according to this guy, they are technically hyperosmolar, but they do not have HHS because they're well. That's the important thing. So these patients are sick. So HHS does not cause ketosis and it doesn't cause the acidosis, but you can get an overlap. So some patients have DKA and HHS and they need escalating and they need, specialist input. So if they have significant ketones or acidosis, then you'd go down the DKA route prior to the HHS route. So the pathophysiology of HHS is a little bit simpler than DKA. So you've got hyperglycemia, so high glucose in the blood over a period of time. We're talking days to weeks, not hours like we are with DKA. And it causes an osmotic diuresis. So essentially we're talking again, you start trying to pee out blood glucose. That drags the water and the electrolytes with it. But this happens over a period of days and weeks. As you start getting dry, the degree of hyperglycemia gets worse. So it just becomes like a vicious circle. So your blood glucose goes up, you get more osmotic diuresis, you get drier, your electrolyte drain gets worse. So everything is much more severe from that point of view than in DKA. So when I mentioned before, the fluid losses in DKA are around 100 mils per kilo. So an 80 kilogram person would be in a deficit of 8 litres. These patients can have fluid losses up to 220 mils per kilogram, which would be a 17 litre fluid deficit in an 80 kilogram person, which is obviously horrendous. And in addition to that, these patients are usually old, frail, and crumbly, and that is why they're so sick. So if you just remember that that is how sick they are, then you won't start diagnosing people in clinic with HHS. So risks: severe dehydration, obviously we know, so hypovolemia, electrolyte derangements, AKI. Risks of cerebral edema and osmotic demyelination. So osmotic demyelination, which used to be called central pontine myelinolysis, it's the one that we always associate with people that have a very low sodium, and then it comes up very quickly when everyone panics. But that can happen with the fluid shifts associated with just being this dehydrated and the because of the hyperglycemia. And then if we start shifting everything back with the treatment of fluids, there is a risk of osmotic demyelination, which of course can associate with coma, seizures, death. The other thing is these patients, as I mentioned, they're old, they're frail, they're crumbly. Some of them, a lot of them, will be unconscious, so they're really high risk of pressure sores and diabetic foot ulcers. So we just need to bear that in mind as well. And they're really, really, really high risk of blood clots. So not just your DVT and PE, but things like ischemic limbs, strokes. So these patients need their dolteparin as well. So our aims of treatment are to restore the circulating volume, correct their electrolytes as needed, normalise the blood glucose, normalise the osmolarity, prevent the complications I've just mentioned, protect the feet, and escalate early. So these patients are unwell, so they probably all do need a senior review really, and referral to diabetes teams. So out of these options again, what is the treatment?
IV fluids.
Correct.
Variable rate insulin,
So not insulin.
not insulin.
So I will come to that in a minute, but importantly, do not start insulin on these patients unless they're also in DKA. So it's just fluids, 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 and more fluids. So we use normal saline, and what we're aiming for is positive 3 to 6 litres in the first 12 hours. Obviously, this depends on the patient, but I've highlighted it's a positive balance. So it's not that we just give them 3 to 6 litres in 12 hours, it's that they are positive that much in 12 hours. So obviously we need to account for their urine output, bowels, insensible losses, sweating. If they've got a fever or anything like that, it'll be even more. So we want to be positive, very positive within 12 hours. That 80 kilogram person I mentioned who's got a deficit of 17 litres, we're not going to be correcting 17 litres worth in the first 12 hours. We would expect that to take a few days, but we need to be getting comfortably positive in the first 12 hours. Identify and treat precipitating factors. So, you know, again, you've got the ones that just didn't know that they had diabetes, that have just been ignoring their polyuria, nocturia, and all that sort of stuff at home. But other times it may be, you know, they've got an infection or something else going on. Give their prophylactic or treatment anticoagulation early. So as I say, they're at really high risk of clot. So if they look like they've got a DVT or something, treat them straight away. And if not, again, these patients, if they're in resus and they're unconscious and, you know, they're either even higher risk again, aren't they? So they're really dry, but they're also possibly unconscious and not going to be moving. So we need to give them their prophylactic dolteparin at 10 p.m. instead of waiting until the next day as well. Foot protection. So as I mentioned, they're really high risk of pressure sores. So, you know, they'll have optimal nursing care on the wards, but sometimes something that's often forgotten with these patients is their feet, and it's their heels that will go. They'll start breaking down. So you can get those, I tried to remember the name for this earlier now, it's completely gone out of my head, those big like cushioned boots basically that they just need to be in, and we want the feet not to be pushed up against the bottom of the bed, especially like tall people. We just need to make sure that that's not happening. Frequent reassessment. Okay, so we'll come to the insulin. I'm going to mention this again, I think, in a few slides' time, or possibly the next slide. We only start IV insulin if the improvement plateaus with fluids. So we start fluids and we monitor their blood glucose every hour, and we're aiming for a fall of between 4 and 6 millimoles every hour. So some of these patients, they come in and their blood glucose might be 60, 70, really, really high. So we're going to have to monitor them with VBGs, and we do it every hour, and we're aiming for around a drop of 5 every hour. If it falls really quickly, which it will with insulin, that's when you're at risk of osmotic demyelination. So that's when everything starts shifting round, the fluid starts shifting in and around the brain, and that can be really dangerous. So we want to bring it down, not too quickly, so 5 every hour. And if it gets to, let's say, 70, it comes down to 40, and then it just stops, and we're happy that we're giving them plenty of fluids, only at that point do we consider IV insulin. And it's a fixed rate, again, just like DKA, but it's half the rate. So with DKA, it was 0.1 units per kilo per hour, so 8 units in an 80 kilogram person. With HHS, it would be half the rate of that, so it would be 0.05 units per kilo, which would be 4 units in an 80 kilogram person. So we're doing hourly using capillary blood glucose, but obviously the capillary blood glucose probably, it stops at 27.8, so we'll probably need VBGs realistically. And we can also use the VBG to calculate the serum osmolarity. Now, importantly, when you do a serum osmolarity and you add it onto your UNEs, your lab bloods, that is 2 sodium plus glucose plus urea. We obviously can't get a urea off a VBG, so we just use the calculated one to get it quite quickly. And as long as we're using the same type, either we're calculating it ourselves or we're getting it off the lab one, then we can monitor it. So we just monitor it to make sure that's falling adequately. And we just have to keep an eye on them because we'll be giving these patients like a litre of fluid every hour, something like that, possibly. So we just need to be keeping a really close eye on them. IV insulin only if the blood glucose stops falling despite adequate fluid resuscitation. If they are also in DKA, we will be treating the DKA. So in that case, they will already be on IV insulin. That takes the priority. If they're sort of mildly in the middle, which I think we had recently on our AMU, so ketones aren't nothing, they're greater than 1, or they're a little bit acidotic, but not meeting the DKA protocol, I would start with fluid resuscitation and see how they go. But those patients, they're really complicated, so they'd need escalating to, realistically, if someone rang me, I might even ring the consultant just to check, so they are quite complicated. So if we were to start IV insulin on a patient with a blood glucose of 70, it would fall really quickly, and that's the danger. So we want it to just fall at a nice rate, and fluids should do that. 0.05 units per kilogram per hour. So pitfalls: the hyperglycemic hyperosmolar patient, they don't need 17 litres of fluid pouring into them. Then you've got the elderly, frail patient with dementia and hypernatremia. So in 2 weeks, there's a talk on hypernatremia, which this will be mentioned. So you get these elderly people, demented patients, that basically they lose their thirst and they just sit there and just become crumbly and they just don't drink anything. And they, a lot of them have diabetes as well. It's tricky to know whether they have HHS or whether they just have hypernatremia because they're so dehydrated. So those patients can be tricky and they need escalating as well. But it's good to be aware that they may not have HHS, they may just be hypernatremic. Oh yeah, so this is really important. I don't know how many of you have the MD Calc app. I find it really useful, but you can just Google as well. So you may be aware that you can get hyponatremia, which is a pseudo hyponatremia secondary to high blood glucose. There is a calculation, I don't know how you do it, but you can get it on MD Calc, where if you type in what the sodium is and what the blood glucose is, it tells you what the actual blood sodium is. So for example, I did it earlier today just to check that it works. If you've got a really high blood glucose of, let's say, 50 and a sodium that's coming up on a UNEs of 120, if you calculate it for the blood glucose, it's actually like 132. So it's actually normal. So what you'll find is some of these patients will be hyponatremic, And people will panic, like, oh, what should we be doing with them? Should we be fluid restricting? Should we be giving them fluid? Should we be checking their cortisol and all this other stuff? You don't have to. And the other thing that you don't have to do is you don't have to panic when it suddenly shoots up when the blood glucose falls, because it's fine, because it's a pseudo hyponatremia. It's not really that low. It's just interfered with by the blood glucose. So that's just something to be aware of as well. Inadequate fluid resuscitation, obviously people are terrified, understandably, of giving that much fluid to a crumbly old person. When to initiate IV insulin, and just being aware that some people can have mixed DKA or HHS. Failure to anticoagulate or protect the heels, so just cautions, just remembering to look at everything and think about when potential problems going forward. Okay, does anyone want to ask me any questions about HHS?
Is it common?
No, it's not common at all. In fact, next slide, relatively uncommon. So you get a lot of patients that have hyperglycemia, and you have a lot of patients that are technically hyperosmolar, technically, but true HHS is actually really uncommon. I think I've not seen that many, and they are sick. So if you're looking at someone that's like, they don't look that sick, probably not HHS.
Does it tend to be in a certain age group, Nasheen? Have you seen in your experience?
Yeah, so usually HHS is just type 2s, and they're usually, because obviously type 2s is usually older patients, but these days we are seeing younger patients with type 2, so it is something that we just have to be cautious that, a young relatively well-looking person could be presenting with a first presentation of type 2 diabetes. So it's just something to keep in the back of your mind, but usually it's older people, and that's what makes the mortality so high. So as you can see at the bottom right of this slide, mortality is up to 20%. I've seen one who's a young-ish man, I think. I can't remember if he's in his like 30s or 40s, so yeah, pretty young, who it was his first presentation of type 2 diabetes, and he ended up in ITU. And he had I can't remember, his HbA1c was something insane, like 160, 180, and his blood glucose when he first presented was like 70 or 80, just ridiculous. He must have been having symptoms for weeks, but it's such non-specific symptoms that people kind of ignore them. And I think this man, he wasn't overweight, he was quite, I don't know how it happened to him, but it did. But usually you do tend to associate it with the elderly, and that's why the mortality is so high.
Can I ask something? The medication review on these patients with HHS, is, for instance, like elderly patients are on thiazides, or if they're epileptic, do we stop those medications or do they continue?
So anything that's going to worsen things like an AKI, dehydration, so the diuretics, stop the diuretics. They'll almost certainly have an AKI. So you do the same as you would with an AKI. Things like anti-epileptics, obviously that sort of depends on a risk benefit, but I'd probably say that you wouldn't want to stop someone's anti-epileptics. Are you thinking of that because of the hyponatremia?
Yeah, and if they're really poorly, but obviously they will ask for substitutes, but I didn't know, would we
So with the hyponatremia in this circumstance, because the hyponatremia isn't a true hyponatremia, it's actually a pseudo hyponatremia, you don't treat it the same.
Oh, right, okay, yeah.
So essentially, when the blood glucose comes down, it will just pop back up to normal. So you can be pretty well reassured that and if you just Google like MD calculated serum, I'll find it at the end actually because I had it on my phone earlier. It will actually tell you that the sodium isn't actually low, it's just coming up low on the lab bloods essentially.
Okay.
So you don't need to do all those extra bits. If someone's got I'm going to go over this next week actually. If someone's got a hyperosmolar hyponatremia, you don't have to do all that other stuff that you normally do with hyponatremias. You don't have to worry about it as much.
Okay, fine. Thank you.
All right. Anything else? So this is just a bit of a summary slide. I've underlined usually because obviously, as I said, DKA can get in, not necessarily in type 1s. Type 1s are usually younger, more well patients, but not necessarily. It's just being cautious, really. The important thing to remember is that with HHS, the fluid losses are unbelievably high, and the blood glucose will be really high as well. but it's not that common, but we do need to identify it because there is a really high risk of mortality.
Right.
So go through a few bits of hyperglycemia out of hours. So this is something that I always heard when I was like an F1 on nights, that just keeping giving patients PRN insulin here and there isn't very good. You know, you're not managing them properly, blah, blah, blah. But then what's the other option? Is it better to commence a variable rates, you know, a sliding scale out of hours? I used to think it was, but then I don't know what you guys think. Actually, if I was a ward nurse looking after however many patients on nights, you know, it's not ideal to have patients on a sliding scale when they need to be having the blood glucose monitored every hour. It's not necessarily going to happen, is it? People are busy. So if they've got a well patient, we want to be doing things that will keep them off IV insulin. We need to be thinking about, you know, why are we treating this hyperglycemia? What are we actually aiming for? So I've come up with like a few things to think about that I think I would have found this really useful when I was a ward F1 and SHO, and I'm sure you guys will find it, you know, helpful as well, I hope. So you want to know, how is the patient? You know, what are they actually being treated for? What type of diabetes do they have? How high is the blood glucose? So are we talking a hyperglycemia of 18, or are we talking about greater than 27.8? Is this a new thing, or is it always like this? What treatment are they on? Sometimes you might want to know, when did they eat? So if they just had like, you know, a bag of Jelly Babies and then we've checked it and it's 25, well, yeah, it will be. When is the medication due, and do they have ketones? So we'll break it down. So we'll go the patient themselves. Are they well? So when I say an A2 assessment / end of the bed, I literally mean you can just say to the nurse on the phone, you know, they're ringing you, the blood glucose is 22. Is the patient fine? They'll just say, yeah, they're absolutely fine. They're completely well in themselves. Or no, there's something wrong with them and they're also hyperglycemic. Are we doing this to them? Have we given them steroids? Do they need tight control? So patients that are, you know, wound healing, had a surgery, or they've had an MI. Oh God. They might need tighter control than someone that came in with like, you know, fall, funny do, or something like that, that we might not be quite as worried about. And do they have symptoms of hyperglycemia? So that would be polyuria, polydipsia, blurred vision. What type of diabetes do they have? So is it type 1, type 2, or other? Sorry. And what treatment are they on? So type 1s will obviously always be on insulin, and some of these can manage their own. Will be able to manage their own insulin, and actually when they come into hospital, their insulin's taken off them and someone else starts messing with their diabetes, and actually if you just left them to their own devices, they'll be fine. So Daphne, for those of you that haven't heard of it, it's a dose adjustment for normal eating, and it's basically teaches people with type 1 diabetes how to change their own insulin doses depending on what they're eating, if they're sick, if they're drinking alcohol, if they're exercising, and and you know, the ones that are trained in Daphne are really good, and you should just be able to leave them to it. So what investigations do we need to do? So if we know what the blood glucose is, they probably won't need a VBG, but if it's greater than 27.8 or equal to 27.8, we need a VBG to see how high it actually is. We can look at their blood glucose chart. If they're new into the hospital, a HbA1c is really useful. So you diagnose diabetes when HbA1c is greater than 48. Really good control would be 48. Obviously, as it gets higher, then we can imagine that their blood glucose is always high. And when do we need to check ketones? So if someone's sick, someone's vomiting, if someone always has a blood glucose of 20, we don't need to continually check their blood ketones. But if it shoots from 20 to 30 plus, then we might want to then. And if they always have good control, and suddenly it's 17, then we would check it. And if they're sick, septic, vomiting, abdo pain, all those sorts of things, basically anything that indicates they might be going into DKA, then we'd check it then. So we start getting concerned when it's greater than 1.5 or urinary ketones greater than 2 pluses. Options are, we can do further investigations. So if we're looking into checking that they're not in DKA HHS, so we can consider that. We can do nothing. So if we just say, they look absolutely fine, that it's not that high, they have no ketones, I'm not worried, that's an absolutely fine thing to do, especially in the middle of the night. We can refer to the diabetic specialist nurses. We can treat people with oral medications, but I'm not going to start going through all that, don't worry. We can amend their usual insulin prescriptions. So if they're already on it and they're always a bit high, then we can start changing their doses. So we usually say that we change things in steps of 10 to 20% every few days, depending on the insulin type. So if they've just had it increased last night, I wouldn't start messing around with it. If it hasn't been changed in days, then I'd be happy for you to mess around with it. And the other thing is we can give PRNs. So in Sheffield, we always use Humalog as their PRN, unless they're already on Nova Rapid or whatever at home. And we usually go with sort of 4 units every 2 to 4 hours, depending on how high, but it depends on the size of the patient. So if they're really prone to hypos, or they've got renal failure, or they're really skinny and tiny and frail, then I might just be a bit more cautious and just give them 2, but something's better than nothing. So if you want to err on the side of caution and just give them 2, that's absolutely fine. Then the other option is obviously a VRI. So this is the Daphne sick day rules. I've split into 2, so you see it goes over 2 pages. But essentially, the important thing is how often they need to be checking. So if they're feeling unwell at home, this is, for them at home, but it's good for us to know. And you can just Google Daphne sick day rules and this comes up. If there's no ketones, i.e. less than 1.5, but they're not feeling very well, they just need to keep an eye on things, sip water and keep an eye on their blood glucose and ketones every 4 to 6 hours. If they have got ketones greater than 1.5, then we need to be doing it every 2 hours. And then to work out, these are the ones with type 1s the type 1s that are already on insulin. We can work out our PRN dose based on their total daily dose, which is their long-acting insulins plus their short-acting insulins that they have over a 24-hour period. And we can give them 10% of the total daily dose every 2 hours until the ketones clear and the blood glucose improves. When the blood ketones start getting over 3, obviously, then we need to be doing VBGs and things like that and treating DKA if they're in DKA. So, how long have we got left? We've got like a few cases. They're quite quick.
Mm-hmm. Yeah, we can go through them.
Yep.
Yep.
Okay. So we've got Mr. AS. It's 2:30 a.m. because it's always 2:30 a.m. when these things happen. 68-year-old man, type 2 on oral treatment, metformin and anagliptin. So they're both quite benign treatments. They're not going to cause hypos or anything like that. Blood glucose is 18.8. There's a message on the Heart of Hours board. This patient is very hyperglycemic. So does anyone want to ask some questions and just see, what information do you need before you can decide how much you care about this blood glucose of 18.8?
Well, you'd want to know if, first of all, he'd had his oral medication for the evening, because sometimes they don't.
Yeah, that's absolutely correct. Yeah, I don't even think I've got that on my list, but that is right. Yeah.
Also, usually about that time, they'll maybe add a few biscuits or some toast, something like that. So I'd want to know what he'd eaten.
Correct.
And then I would ask whether or not, just for completeness, really, I'd ask for them to do either urinary ketones, to see if they have them. Don't always, but I'd probably get someone else to do it, or I'd just get them to monitor it, because it's pre-meal, isn't it, that we need to be too bothered? Is that right? Have I got that wrong?
Yeah. So it's when we're targeting patients. Actual what targets do we want their blood glucose in? We do tend to do fasting, so first thing in the morning when they wake up and before meals and before bed. Obviously this is at 2:30 in the morning. Why they did the blood glucose, no idea. So is there anything else you want to know about the patient?
Whether or not he's well.
Yeah, exactly.
See if he's got any kind of infection brewing, maybe, because that can increase your blood glucose.
Yeah.
And if he's well, then that doesn't really do that much.
Yeah, that's exactly right. Yeah. So the first question is, how is the patient? So I've said this fictional patient is well. He's of the normal. He's been well all day. He's now asleep. He has not complained of any osmotic symptoms. Again, the question would be, why have you checked? But anyway, he's been treated for a fall, and he has a UTI, and he's just on oral antibiotics. And his blood glucose normally all day it's been between 12 and 15, and then now it's 18. But yeah, maybe he's eaten some biscuits before bed, probably. And do we have any ketones? No. So what do you want to do for this patient?
I'd probably just monitor him and see what sort of trend his blood glucose have been for longer than that like 24-hour period, and if it's consistently high, I'd just ask the ward nurses to refer him to diabetic nurses to see whether or not he needed a medication review.
Yeah, that's correct. Yeah. So when you say you want to monitor him, when do you next want them to check his blood glucose?
I'd probably just get them to do it at the same. I'd probably get them to do it in like 2 to 4 hours, something like that. Just to check that it was going down and not going up for whatever reason. But then, because obviously he's well, so it's not like it'll need doing like an hour later or
Yeah.
2 or even 2 hours later. Really, probably just do it. If it's 2 a.m., I'd get them to do it first thing in the morning when they were doing his jobs.
Exactly. Yeah. So I'd get them to do a fasting blood glucose before his breakfast. But I agree. I'd pretty much do nothing, but we can refer to the DSNs as well. So I've said we could do nothing. Some people really don't like doing nothing, and when the blood glucose starts creeping up, sort of over 17, you can do the PRN Humalog thing. I personally wouldn't in this situation, but if they gave him one-off dose and it came down to like 11 or whatever, I wouldn't be mad. You know, it would just be fair enough. But I personally probably wouldn't do that. And then, like I said, you want to know the longer term trend. So let's say he only came in yesterday, so we'd have to wait days for a trend, or we can check HbA1c. So if his HbA1c is like around the 48 sort of number, then we can say, oh, it's probably high because he's got a UTI. Or if his HbA1c is like 80 something, you know, relatively high, you can say it's probably like this all the time, but the DSNs probably need to come and have a look at him, like you say, for a medications review. So that's perfect. Great. So let's say it's the same guy, Mr. AS. It's 2:30 again. Blood glucose is 18. Same type 2 on metformin, allogliptin. He's got high blood glucose. So this time, he's not very well. And he's come in under the surgeons with abdominal pain, vomiting, being investigated for gallstones. And we don't have any blood glucose. He's only just come in, and it's 18.8, but his HbA1c was 48. So we would expect that normally he has really like perfect control. So normally we would say, you know, it's less than 10 normally. It's now suddenly 18.8. He's vomiting, he's got abdominal pain, and he's just not very well. So what would you want to do with this chap now?
Fully review him again, do an ABCDE, go and send someone to go and review him, and possibly do an ABG to see if he's acidotic, get the blood ketones done. Obviously, and then act on the results. Yeah.
So important things about that. So you only need an ABG if he's hypoxic. So VBG would suffice.
Oh, sorry, ABG.
Yeah. And with this man anyway, he may need a VBG if you're worried about his lactate or something like that. But for a patient, you do the ketones first, and if his ketones weren't raised, then he's not going into DKA. So from that point of view, you wouldn't need a VBG. So you do ketones first. If they are raised, so urine greater than 2+ or blood ketones greater than 3, then you need a VBG to look for DKA. But if his ketones aren't significantly raised, from a DKA point of view, you don't need a VBG. But for this chap anyway, let's say he might be septic or something, he probably does need a VBG, doesn't he? So yeah, and then so let's say his ketones are, well, maybe I've said that on this next one. Ketones. So let's say his ketones were 1.2, so he's definitely not going into DKA.
Okay, no.
This chap probably needs a VRI, doesn't he?
Yeah.
And the reason for that is he's vomiting and he's not very well. So we're not going to be able to really manage him with anything else. We're not going to be able to give him oral treatment, certainly. And, you know, he's vomiting, he's not going to be able to eat and drink. So we're probably not going to want to just keep giving him subcut PRNs. Going forward, we need to figure out what's wrong with him, don't we, and treat it. So something's going on. He might have pancreatitis, for example, this guy, but or sepsis or something like that. So next patient, a younger man, 45-year-old, who has type 1 diabetes on Levemir and Humalog, and he's coming with COVID. And his blood glucose is shot up to 24 before he goes to bed, and he's on high-dose dexamethasone. So he's on high-dose steroids, which push up your blood glucose. So what do you want to do?
We'll ring them again, triage the message, ask them how the patient is. The high BM is due to dexamethasone because that will increase it. But then, was he diabetic? Sorry.
Yeah, sorry, I'll go back to the slide. So he's type 1 and he's on insulin normally.
Yeah, and then possibly give him a stat dose of Humalog PRN to see if that brings it down and refer him to the diabetes nurses. But depending on the clinical situation, as long as he's well with it and his COVID's not compromising him.
Precisely, yeah. So it's basically how is the patient, isn't it?
Yeah.
So is he well? Has he got, is he eating and drinking? So he's on 8 litres of oxygen, but he's stable. So that's from his COVID point of view. And he feels awful, but he's got COVID. He doesn't have any specific symptoms of hyperglycemia. He can eat and drink and he's not vomiting. So that's all quite reassuring. Does he have ketones? 2. So what do we want to do from this point of view? Now that they've got to this stage, what do we want to do?
Would you do a VBG?
So not necessarily, because unless you're doing it for another reason. So if there's another reason, like, for example, he's septic and you want to know his lactate, but with ketones of 2, he doesn't have DKA. So you need ketones of greater than 3. So with these patients, we
just
can actually manage
randomly
them with subcut.
pH.
Say again?
I was just thinking randomly, oh, I need a pH there.
No, that is exactly, it's the right, like, going in the right direction, but it just sort of saves you a job, really. You know, patients that, I mean, if he's acidotic, he probably won't, from a ketones point of view, he isn't in DKA. So if he is acidotic, he'll be for some other reason. So he may well be going into type 2 respiratory failure, or he may have a lactic acidosis. So we may want to do a VBG or an ABG, because he's on 8 litres of oxygen, if he's not already had one. But from the diabetes point of view, he isn't in DKA, and these patients can actually be managed just with subcut insulin.
Okay.
So he is definitely trained, but obviously he's been feeling so rough and just letting the doctors and the nurses just get on with whatever they're doing and not really paying attention to things. And he's usually really good at it. So with this patient, if he's feeling all right and up for it, he could probably manage his own diabetes. So what we would do, this is a sort of patient that we can just keep giving PRNs to bring it down. So he could have Humalog, and because he's type 1 and he's on insulin already, we would be able to work out what his normal insulin regime is. So his Levemir plus Humalog, how much do you normally take every day? Work that out. Some patients might take 40, some patients might take 60, and then we divide it by 10, and we give them 10% of the total daily dose every 2 hours. So that's something that we can do with these patients. So it's not something that we do that often, but that's probably because not that many people are really very good at managing their own diabetes, to be honest with you. But if I was happy with them, and he was a sensible guy and he's happy to do it himself, I would honestly just let him get on with it. So obviously you still need to prescribe it, but you can prescribe a range, 4 to 8 units every 2 hours, and then he can get on with it until his ketones have cleared, which would be less than 0.6. So does he need a VBG? Not for this purpose, possibly for another purpose. And we'll do blood glucose and ketones every 2 hours until his ketones are less than 0.6. If you did it more frequently than that, every hour, that would also be fine, because he's obviously not a very well man, is he? And going forward, so this, if we felt like we could, while he's an inpatient, he may well need his everything increased. But the most important bit about this is, like you said, refer to the DSNs, because when he's on steroids, everything's going to go up, and then when his steroids stop, everything's going to go down again. So it's a bit of a tricky one. So DSNs are important with this chap. So let's say same guy.
A guideline in it.
Say that again.
So there is a guideline, I think, on the intranet, isn't there, for hyperglycemia induced from steroids. I'm sure I've seen it.
Yeah, but I think that's not for people that are already diabetic. I think that's for like the new ones that have just become hyperglycemic, and that they are often treated with glipizide. But yeah, I feel like I will have read it at some point, but I think that wouldn't be applicable to this chap. because this chap's just he's already type 1, he's already on treatment, everything's just needing more, as opposed to the ones that are like either just on orals or not known to be diabetic that have been started on steroids.
Yeah. All right, thanks.
All right. So this time he's same guy, so he's definitely trained, he knows what he's doing, but this time he's just feels awful. His blood glucose is really high, his ketones are climbing, and he's vomiting and not able to eat and drink. So would this guy be appropriate to just keep giving subcut insulin to?
No.
Yeah, I would agree with that. This guy needs a VRI. So he's vomiting. He'll need a VRI. And we do need to keep checking the ketones. Now, with these sorts of patients, it might be that the VRI isn't actually enough, and that his ketones go up again, and that then he might end up in DK. But at the moment, he doesn't need the fixed rate. He needs IV insulin, but he doesn't need a fixed rate. He's not in DK at the moment. But now he is. So now, same scenario. He's vomiting. He looks terrible, but his ketones are 3.8. This guy needs VBG, and probably, let's see, he's had his VBG. His pH is 7.2, bicarb is 12, potassium is 4.8. We go down the DK treatment pathway in that case. All right, and I think I've got one more. So frailty unit 4 AM. A 90-year-old lady who was admitted with urosepsis 2 days ago on IV antibiotics and slow IV fluids. She's not known to have diabetes, but she's very flat. So because she's so flat, which is probably because she's got urosepsis, but someone thought better check that she's not having a hypo. And the blood glucose is 27.8. Ketones are 0.4, so they've got a ketone meter on that ward. So what do we want to do with this lady?
We probably want some bloods off her. Blood glucose.
Yep.
UNE.
Yep.
FBC, and she'd need assessing as well.
Yeah. So with this lady, you could do a VBG to get so with the blood glucose being 27.8, remember that's the actual upper limit of the monitor. So for this lady, just to get a quick, rather than wait for the lab bloods, it would actually be while you do the lab bloods, do the UNEs and all that, but also it would be quite useful to get a VBG just to see what the blood glucose actually is, because it might be 27.8, it might be just 28, but it could be anything. So just always remember that the hospital meters only go up to 27.8. So if it says 27.8, it's higher than that. So yeah, this lady needs assessing, doesn't she? And blood sending. So done A to E. So that looks fine. She looks dry. She's a little bit on the tachycardic side, a little bit on the hypotensive side, but not too bad. She's rousable. We've done a VBG. Her blood glucose is 47. Lactate 3.8. pH 7.31, sodium's at the upper end of normal, 149, potassium's 5. So this lady's quite sick, isn't she?
Yeah.
So, and lab bloods, they're from earlier today, so we've not got the rest back yet that we've just sent at 4 AM. But so what are we thinking about this lady now?
So she's hyperglycemic. She looks a little bit dry, lactate's high. Well, she looks a lot dry, really. Yeah, acidotic. Sodium's high and potassium's high as well, and renal function's probably going off a little bit.
So what do we think the diagnosis is?
I mean, she technically could be HHS.
Yeah. So blood glucose is significantly high, and she's not. And the important thing is that this lady, like you just said, she's not well, is she? So, you know. But we've already they did the ketones, didn't they? And they were like 0.4. So we're not thinking that she's going down the DKA route, but she very well might be HHS. So when we've calculated the serum osmolarity, and this is 2 sodium plus glucose, so this doesn't even include the urea, it's 346. And for the diagnosis, it would be 320. So she has HHS. So we give her fluids. We escalate early, we give her lots of fluids, and because her blood glucose is so high, we won't be able to monitor it with a blood glucose meter. We need hourly VBGs to see that it's coming down, because remember, when we're doing HHS, we monitor with the blood glucose. We want it to be coming down by about 5 per hour. And we will obviously refer her to the diabetes team. let's say this is actually the last one now, I think. So frailty unit 4 AM, 90-year-old lady. This time she's not got urosepsis, she's just query UTI. She came in a bit muddled. She's on a bit of trimethoprim or something like that. She's known to have type 2 diabetes this time with CKD, and she takes metformin and glycoside. HbA1c is 70, so she's not particularly well controlled. And she's been a bit muddled today, so she hasn't taken anything because she just wouldn't. And she's just pottering around the ward, causing havoc, as they do. And her blood glucose is 27.8 or greater than 27.8 with no ketones. So what do we think about this lady? What do we want to do?
A lab glucose again. We want to assess her clinically, how she's doing. If anything's deteriorated, and send some bloods off again because it's above 27.8.
Yeah,
to reading.
Exactly. So we want to know what her blood glucose actually is. So we're doing assessment. She's well. She's wandering around. She'll drink. If you give it to her, her new score is 1 for a temperature of 35.9. So we do a VBG and send off some lab bloods at the same time. Blood glucose is 30, so it's just over that, limit. pH is fine. Lactate's fine. And these are the bloods that have come back. So her urea is high and her creatinine's high, but we know she's got CKD and it's not an AKI. She's not particularly dry for her. When you work out the serum osmolarity, so calculated serum osmolarity, 2 sodium plus glucose is 306. But on the bloods, where it includes the urea, it comes back at 329. So technically, she's hyperosmolar, isn't she? She's hyperglycemic. But would you say that this lady has HHS?
No.
No.
I agree. She's well, isn't she?
Yeah.
And she has a HbA1c of 70, so she's probably always hyperglycemic. She's always got high urea because she's got CKD. So her bloods are always probably like this. So you're absolutely right. She doesn't have HHS. She's just fully controlled type 2 diabetes and a lady that hasn't been taking her medication. So what would you want to do with this lady? How would you treat her?
Try and give her a meds.
Yeah.
Encourage
That's so try and give her a medication. Now glycoside is good at bringing things down. Metformin doesn't have as much of an effect, especially not straight away. But with this lady, with a blood glucose of 30, would you want to consider a variable rate? And do you think it's safe in this lady?
No.
Yeah, I agree.
I don't think it is. She'd probably just pull a cannula out and
it's non-compliant.
wonder it around ward.
Exactly.
So I think I would probably
go on.
Try and give her a medication, but then refer her again to the diabetic team to look at maybe increasing, like making sure that she's taking a medication for a start if she's muddled all the time, or if she is and it's still poorly controlled, then she'll need a medication increasing over time.
So she may need a medication increasing. Let's say obviously at home she may well be better than this because the HbA1c is 70, so it's not good, but it's not horrendous. So she probably does she probably is taking something at home. I completely agree. Variable rate isn't safe in this lady. She's going to end up falling over a drip stand or something, isn't she? And the other option is, if she won't take anything orally, we could actually give her a bit of subcut insulin. So although she's not type 1 and although she's not already on insulin, her blood glucose, that does need treating. We can't leave, I'd be happy for you to leave a blood glucose of like 17 overnight, but I would rather her not have a blood glucose of 30 just left. So I'd rather not do nothing. And it may well be that the safest thing is actually to give her a bit of subcut insulin, because obviously she doesn't have to take that. Someone can just sort of, jab her. So she's an old lady with CKD, so you might want to be cautious. But I think giving her a little bit of insulin and then monitoring her blood glucose every 4 hours probably would be quite good. We just need to see things coming down. But yeah, I agree. We probably then need to get the DSNs involved while she's an inpatient. Okay, so summary. DKA is a common condition which could potentially be fatal. HHS is uncommon, poorly managed, and frequently fatal. DKA requires IV fluids and IV insulin at a fixed rate of 0.1 unit per kilogram per hour, so whatever they weigh divided by 10. HHS requires fluids, and only IV insulin, possibly later. They require frequent monitoring, both for the complications of the condition of itself and for the amount of fluid that we're giving them that can cause complications itself. And they should both be referred to the diabetes team. And that's the end. So sorry, it's a bit longer than I expected actually. But I hope you found that useful. And if you've got any questions, then I'm happy to try and answer them.
Thanks,
Thank you,
Nasheen. That was great.
Yeah, it's been brilliant. Thank you. Could you send us the presentation, please, Natasha, if that's all right? I mean, sorry, Nasheen. If that's all
Yeah,
right.
of course. Yeah, that's fine.
Is that all right? Then I can share it with the rest of them.
Any questions?
Not at the moment, thank you. There's a lot of information to take in there, but it's really,
Yeah.
really interesting. Lots of sort of bits that have just stuck out for me and thought, right, yeah, I remember that. I'll take that with me.
Good.
So yeah, thank you very much.
You're welcome. If anyone has any questions that they think of later, then feel free to email me or just grab me when I'm around the hospital.
Great. Thanks
Thank
so
you.
much, Nasheen.
No problem.
Thanks, everybody.
Thank you. Bye.
Thank you very
Thank
much.
you.
You're welcome.
Bye.